So I ask all the speakers if they switch on their cameras, and also if the panelists kindly switch on their cameras. It gives me a great pleasure to come to the panel. Mary O'Kane, consultant weight management dietitian at Leeds Teaching Hospital NHS Trust. She always reminds me that she is retired, which I still don't believe. Dr. Professor Barbara McGowan, consultant endocrinologist at Guy's and St. Thomas NHS Trust, and Dr. Carly Hughes, who's a GP and bariatric physician from Fakenham Medical Practice in the UK. And obviously, it's fantastic to see all our speakers as well. So I'll start with a question to Carly, and then we can also hear from other panelists. So Carly, primary care physicians at the front line, really, in terms of providing care to people. Pre-diabetes is all there out in the community. When you see somebody with pre-diabetes, how should a primary care physician approach them? There are now multiple treatment options available. I appreciate there will be local variety or local variation in access to treatment, but there are multiple treatment options. What would you do? How should they approach these patients?
That's a great question, Abd. I'm delighted you've asked, because in Norfolk, we've had some really interesting things with this. I've been very interested in the diabetes prevention program, but when it first came to Norfolk, a lot of GPs were very cynical about it and said nobody will go and it won't do anything. And I just said it will. And we, in our practice in North Norfolk, we had such a high uptake, they had to increase the size of the program and go back and get more money. A lot of people went, and the people that I saw really gained a huge amount. However, absolutely, as Jonathan said, they did tend to be older, better educated people. So really good results. And we proactively screen people for pre-diabetes. We put them on a recall. We offer them all the chance for referral. And we're very excited that now there's virtual opportunities as well, because people are taking that up, because we've got to start offering people help earlier on. So I think in Norfolk, the GPs actually now are really convinced and they're welcoming this. And the only problem is we haven't got anything to help people who haven't got diabetes and may have other obesity-related comorbidities, and they can't sneak onto this. But so we do refer people, and we do keep them on a register, and it's a great program. Thank you for funding it.
Excellent. And how can we make every region in England like Norfolk? Obviously, it should be the UK as well, but considering we are talking about NHS England.
Well, actually, I'm very optimistic. I think that the new generation of general practitioners coming through are actually a little bit more interested and less judgmental, if I'm allowed to say this because I'm over 60, than some of my peers. So although it could happen more quickly, I think that this is gaining traction, and as the results come out and we see the publications, everyone's aware of the huge burden of diabetes on patients and on society and on the NHS, and I think we are going now in the right direction, and with also the huge amount of work done on reducing obesity stigma and educating people about the biology of obesity. Absolutely, as Carl said, once people stop thinking of it as being somebody's fault, if we can push ahead on that one as well, I think it's a very slowly opening door, but I think we are getting there. We just need to keep talking about it, being enthusiastic about it, and going out there and telling people the evidence.
Thank you for that, Carly. It's much appreciated. If I take Carly's point and career point just to Jonathan and say it's fantastic we have an NHS diabetes prevention program. I think we all love the fact that this is a national program aimed specifically to prevent type 2 diabetes. This is really a huge achievement that needs to be acknowledged. However, if we want to take it to the next level, which Carl and Carly mentioned, there are responders and non-responders. There are people who at the end of the NHS DPP would have done great, and that's fantastic, job done. And there are people who not doing as great, where they might need more treatments. Is there currently channels of communication between NHS DPP and intensifying this treatment, whether it is pharmacotherapy or bariatric surgery, or are these patients just lost in the net between the different parties who provide services?
Yeah, thanks for the question, Abd, and really important. It's interesting. You make lots of attempts to land policy, and some you land and some you don't. And this one, the NHS Diabetes Prevention Programme landed, and we've been, resourced well to implement it nationally. I think the conversation has changed more recently, and it's changed, I think, because of COVID. And the fact that raised body mass index, certainly within the obese range, is an independent risk factor for COVID mortality and worse outcomes with COVID, tragically. Many risk factors predict that, but importantly, obesity is modifiable, obviously. And you could argue the same for diabetes. We published data from across England showing the higher risk of COVID mortality in people with actually type 1 and type 2 diabetes. Within those cohorts, obesity was an independent risk factor as well, and glucose was as well. So within diabetes, glucose is a modifiable risk factor, and across the population in terms of COVID risk, obesity clearly is. And that has changed the conversation. You will be aware, I don't know how many we have online listening from outside the UK, but many will be aware that there was a UK government announcement last July with clear intent, statement of intent to do more in the space right across the pathway, which I think is good news for all of us. I loved Carol's diagram of, of course, start with, population level lifestyle recommendations, more personalized lifestyle interventions, drugs, surgery, and it is a cascade. We must not forget that against each of that sort of raft going up Carol's pyramid, the unit cost goes up considerably as well. And that's highly relevant for national implementation and policy. The sugar tax, the unit cost per person to implement the sugar tax was near zero. There's a significant cost, unit cost with the diabetes prevention program, but much less than going on one of the drugs and going. What is required is to go through a multidisciplinary specialist clinic to get those drugs. And so the unit cost for that is much, much higher. And we know that bariatric surgery is much higher cost as well. Not to say that we shouldn't be doing it. I would love to see us, and call me the eternal optimist, but let's keep our fingers crossed that we have opportunities in the next few years now to really plug the entire pathway and each element in that pathway. But we have to recognize the the practicalities, the unit costs involved, etc., etc. So have I gone some way to answer that question, Abd? I think real optimism actually on the back of the government's announcement last July.
Absolutely. And I think just add a small point here is, I think people who are taking care of the patients, whether they are clinicians or dietitians or primary care or secondary care, they need to know that if their patient didn't respond to the NHS DPP, there are other options available, and they need to see their local services availability towards these services, and please utilize them. We have a nice technology appraisal for pharmacotherapy, and we have obviously bariatric surgery are other options available to people who do not respond to these treatments. But I totally agree, and we need to be proactive in providing these treatments. Thank you for that, Jonathan. Can I ask Jaco? Now, your experience with diabetes prevention is far longer than our experience in the UK. So I just want to ask, did it actually eventually in Finland result in a drop in type 2 diabetes incidence, or did it just slow the progression? What happened in Finland since it was introduced?
Well, when we look at the incidence of diabetes based on the medications, because we have reimbursement for the medications, diabetes medication, the rates have been going down for the last 5 years. Now the question is then that to what extent it is due to A1C being implemented, even though in Finland we are not recommended A1C as a diagnostic tool, but it is used in practice and less proper diagnostics implemented. So we don't know about it at the moment, but clearly there is a decreasing trend in the new cases of diabetes. Now, I would like to comment some of the earlier discussions, and the point
Please.
is that of course we, as so we are advisors, we are mentors. People have to change their own lifestyle or take care of their own lifestyle. We cannot do it. So whatever we can do is to serve as a mentors. And unfortunately, at the point when we identify the person to be at the high risk of diabetes or having pre-diabetes, it's basically too late. Something has happened already in this person's life that is very difficult to turn back. And that is a biggest problem. Where is the right time to actually carry out the intervention? It's not in the GP practice. No, that's late. And whether we can do it in the schools, no, it's too early. The school children have so many problems with their puberty and whatever, developing their own lives. Who cares about diabetes at that time? Obesity might be a problem, yes, and is a problem, but this is something else to be tackled in the right way. But where is the right time? I don't think we have discussed this in the health policy. What is the right time for diabetes prevention, type 2 diabetes prevention?
Thank you very much for this, Jaco. It's an important point. And in the UK, we always have these discussions about prevention and treatment. And I think we all agree that prevention and treatment policies need to be implemented simultaneously, treat the people who have the problem and try to prevent it in those who don't have the problem. Nonetheless, it is actually a very interesting question. Indeed, when do you start diabetes prevention? Yeah, I'll be horrified if we start talking to kids about prevention personally on a personal level. So certainly it won't be childhood. Can I just move the point to Barbara? Barbara, as a bariatric physician who work in a tier 3 service, you've got access to multiple modalities of treatment. Do you actually see a role for tier 3 in type 2 diabetes prevention?
Thanks, Abd. I mean, just finishing off on the other question, I mean, I think we should start in utero to intervene. Actually, I don't think we can be early enough, and I'm not kidding. So I think we should be intervening at every step of the way. With regards to me sitting in tier 3 and having lots of treatments available at my disposal, again, that is very limited to capacity. And again, even discussing pharmacotherapy in tier 3, and now we being asked to obviously we're getting lots of requests, but everything is limited by access to tier 3, and we're seeing significant delays in tier 3, not to mention the huge delays with for surgery for tier 4. The role of tier 3, I mean, I think that diabetes services should work hand in hand with obesity services. So the diabetes prevention program is fantastic, but it shouldn't just be for people with pre-diabetes. Obviously, I hope that looking ahead, we're going to have services for everybody with obesity, and it's going to be a seamless pathway all the way from tier 1 to tier 4. We shouldn't be having barriers. There should be a seamless pathway. But I do think there are capacity issues all the way through, and I hope that the government, NHS England, with this sort of resurrection of interest in obesity, which COVID has given us. It's probably the only gift that COVID has given us, as well as, of course, you know, the use of technology, that we can really capitalize on this in the future. But I do think that joined pathways between, you know, because the pathways for diabetes are excellent, the services for diabetes are excellent. But I think we need to piggyback onto those services, and of course, Tier 3 will also play a role. Thanks.
Thank you for that, Barbara. Does the panel have 5 minutes more? Is that okay? Obviously, people who need to leave can leave, of course. Can I just say a question we had from a dietitian? I will ask Mary about it, and it's relevant to Jonathan as well. So there's a dietitian who worked in a UK prison who said, how can she engage such socially deprived, less academic communities in something like diabetes prevention? What do you think, Mary? And I would like to hear from Jonathan after that, if possible, please.
Obviously, most of my experience is actually in the medical obesity clinic, and also for the patients going forward for bariatric surgery. And I'd actually say that most of the population that attend our clinics are actually from those deprived areas. And I think it was really interesting hearing the speakers actually saying that this group of people are actually very good at engaging with services. So I think where we're probably not as good at is actually engaging with maybe the different cultures. And so certainly in our clinic, we will have people from the Black community. We'll also have South Asian community as well. But for some people, there'll be language barriers. And although we're very good in the NHS about including interpreters, there'll be cultural differences. So many weight management services are now trying to get back into the community. But I think the great challenge for me is actually the fact that we've got to do digital services. So I have patients who will use mobile phones, who've got no reception, who've got no internet access. So I think we've, again, have got more barriers and more challenges. And I think it's certainly, as dietitians, it's an area we're looking at, and it's certainly an area that the commissioners are really concerned about and are really trying to address, but we've got no easy answers at the moment.
Thank you, Mary. Jonathan?
Yeah, huge efforts are going in really across health. I mean, COVID has also shone a spotlight on socioeconomic inequalities and ethnicity and you know, all of the dimensions, if you like, that I showed you in some of those slides are relevant to COVID and have shone brighter sort of spotlights on them. But for the diabetes prevention program, we, right from the outset, firstly, we were pleased that first attendees, we had overrepresentation from the non-white ethnic groups at higher risk. We, in the first year, actually, it was just marginally higher from the most deprived versus the least deprived, but that's first attendees. And you've seen my data that you know, the problem is retention. So our first attempt has been to pay the providers more if they retain more. We've got an interesting model which saves quite a lot of money in that we pay our providers for milestones. So when people stop, we don't pay the whole unit cost, if that makes sense. So there are 5 different milestones. So if someone only turns up once, we only pay a proportion. But by selectively weighting payments to try and resource our providers more to retain those harder to reach groups, it has been our first attempt in the space. But if I'm honest, the biggest thing to level up is getting referrals from general practice and having incentives through, you know, things like the GP contract. General practice is fantastic at leveling up and actually achieving engagement with the more deprived communities, whatever shape or form that might take. So our referral route in through general practice has been crucial to get that equity for at least first attendees, even if we're not yet getting the best retention from the more deprived or the South Asian, Black Caribbean, Black African groups, etc. So I think it pans out across health, across employment, across all other things. But I think actually we're going to see a lot more action in the space on the back of COVID.
Thank you for that, Jonathan.
Yeah.
Karel, I just want to ask a final question. I think Carly raised her hand. I'll come back to you, Carly, after the question, just to see if you had another point to add. Karel, you talked about pharmacotherapy. and we know multiple pharmacotherapy agents do reduce the incidence or delay type 2 diabetes. Okay, in the UK, we have obviously a nice technology appraisal, but for those who don't have exactly the same system and listening, how do you choose which pharmacotherapy will you use in a patient for the prevention of type 2 diabetes if they have prediabetes?
I think you use the drug that works. You know, it's really simple, because if you give a patient a drug and the drug does not make them substantially less hungry and substantially more satisfied once they've taken the drug, you know, within the first couple of weeks, you can tell. And if it's not working, stop the drug and go to the next treatment. And I think we can learn that also when we look at our lifestyle changes, because in clinical trials, what we see is the most deprived patients lose exactly the same amount of weight than the wealthiest patients. But the patients who are most deprived are the highest dropouts if it doesn't work. So if things don't work, they vote with their feet. They've got busy lives, they've got other things to do. But patients who are highly, you know, maybe more motivated and a higher socioeconomic class, they will stick with us even if it doesn't work, because they think they need to be better people and they need to constantly. So that's why we can retain, even in clinical trials, we retain people who have higher socioeconomic classes because they are coming back, not because the drugs work better in their cases. So I think, you know, it's this whole point, you know, only use treatments, medications included, if they work. And if they don't work, stop. Because what we've done in the past when it comes to obesity, and even if we think about drugs like rimonabant or sibutramine, these were good medications, but we lost these medications because we were using them in patients that weren't responding or patients that had side effects. So we need to protect the new drugs that we have and not to run the same risks.
Thank you very much for that, Karel. Also, it emphasized, obviously, you highlighted the point very nicely. We need to assess response, and we need to escalate treatment, and we need to not allow that clinical inertia get in between escalating the treatment and, you know, take the lack of response and escalating the treatment. Carly, I'll finish with you. You had a point to add, please.
Yeah, so it's really a point for Jonathan. I absolutely agree. The tier 3 services are much more expensive, and you've got to balance all of the costs. However, the patients that we see are extremely complicated with multiple comorbidities, and actually treating their obesity often doesn't just reverse their diabetes, but improves a lot of other things. And as a GP, there is nothing worse than having somebody there wanting help, really struggling, and not having a service to refer them to. And you know, there were not enough tier 3 services or specialist services before COVID. Many of them have had to temporarily shut down or go remote during COVID. Our own service, which has never had a long waiting list, we have over 100 referrals waiting, and these are desperate people wanting help. And it's really hard for GPs knowing that there are effective treatments available, but not having access to the services. And, you know, this is a real problem for both patients and doctors. And even the functional elements, you know, you can save a lot of money on social care by getting someone able to dress themselves because they've lost enough weight to do that. So I think we're just missing out on some of the complexity, and actually there will be cost benefits if you can do the complex analyses. But because these patients have so many problems, but please don't forget about the people who've already got the severe and complex obesity. They're costing health and social care a lot of money, and there's a huge amount of human suffering involved.
Thank you very much for that, Carly. I guess with this, we're running already over time. I'm absolutely indebted and grateful to all the speakers and panelists on behalf of the Association for the Study of Obesity in the UK. Thank you so much to all of you. And thank you to Novo Nordisk, who were the sponsors. Just to remind people, Novo Nordisk had no control on any aspects in terms of choosing the speakers or the slides or any involvement in planning how we planned the meeting today. But thank you very much for their sponsorship, which allowed us to do the meeting. Thank you very much, all of you, and have a good evening.